So good afternoon, everyone. As dedicated professionals, we all strive to provide exceptional medical care to our patients. However, unfortunately and inevitably, medical errors do occur, and it's our responsibility as physicians to address these issues, learn from them, and ensure that they do not happen again moving forward. As high achievers, these errors are oftentimes difficult for us to cope with because we hold ourselves to such high standards. We're very privileged today to have Dr. Albert Wu join us as our special guest to share his insights about this topic. Before I get into his accomplishments, I just want to outline some ground rules for today. My name is Dr. Melody Ong, and on behalf of Resident Doctors of Canada and the Wellness Committee, I'll be serving as a moderator today. We have about an hour for the session, and our goal is to have Dr. Wu answer the committee's prepared questions for the first half, and then open up the floor for discussion in the latter half. Nonetheless, we want to make the session as interactive as possible. RDoC will be using the hashtag #SecondVictim, and so feel free to do the same. There's a chat panel on the side in which you can feel free to type in your comments or questions for Dr. Wu or myself, or for all the participants in today's chat. I'll do my best to take note and collate some of the comments as they come, and then when appropriate, I will ask them on your behalf. If you would like to directly speak and make a comment, you can also select the raise hand button, and then I will grant you permission when the time is appropriate. That way, so that we're not all talking over each other's voices. Dr. Wu is a renowned international expert on addressing the effects of negative outcomes on physicians. He practices as a general internist and as a faculty member at Johns Hopkins School of Public Health, where I've had the privilege to meet and learn from him. He's truly a very inspiring and down-to-earth individual. He's a leading researcher on the topics of patient outcomes and quality of care and has studied the handling of medical errors since 1988. He's coined the term second victim to describe clinicians who commit errors, acknowledging the significant emotional impact that errors can have on clinicians involved. Subsequent research has shown that involvement in an error adversely affects providers' emotional health and job satisfaction and increases risk of burnout. Dr. Wu has published many influential papers, including Do House Officers Learn from Their Mistakes and Medical Error, the Second Victim. Without further ado, let us welcome Dr. Wu right now. Hi, Dr. Wu. Thank you for joining us. So I guess we'll just jump right into our questions. So Dr. Wu, when did you decide to look at negative outcomes more systematically? What made you interested in better understanding their impact and possible solutions?
So back when I was a resident, in fact, I had a encounter with the team that I was working with. I did internal medicine residency, and I was a third-year resident. And on rounds, one of my interns, who happened to be a family medicine intern. Most of the folks were internal medicine. When we went by his patient's room, said, "Oh, the nurse said he's having chest pain," so he went in and did an EKG. And I said, "Oh, does it show anything?" And he said, "No, it's fine." So we went on. We continued on rounds, and nothing much happened with the patients. The day ended, he went home, the team was on call, and I was on call with the intern who was on. And at about midnight, the patient started having chest pain again. The covering intern did an EKG and said, "Oh my God, look at this. I think he's got cardiac tamponade. I think that he had a procedure. He might have constrictive pericarditis. He needs a surgeon immediately." And in fact, so we got a surgeon. He actually got a pericardial window put in and survived. And the next morning on rounds, we walked by the patient's room, and the original intern was a little bit late, and we walked by, and he said, "And this patient," and then we looked in the room and saw there was no patients. And he sort of paused, and one of the other interns said, "Oh, your patient who was having chest pain from his constrictive pericarditis all day was rushed to the OR last night." And of course, the guy felt you could see that he felt terrible. And, you know, I thought, I sort of, I actually didn't say anything either way. I sort of said, you know, the patient's fine. But the guy looked upset. And afterwards I heard people saying, you know, well, it's not surprising given that he is a family medicine resident, not an internal medicine resident. Do they have to read EKGs in family medicine, or do they just, you know, do they just talk to the patients? They were a little bit harsh. And so I remember that for really for a long time. And when I was, a couple years later, when I was a fellow, I did a study which asked interns to describe the worst mistake that they'd ever made and what happened to the patient and what happened to them. And perhaps not a surprising thing, but a thing that interns reported was, first of all, that they had made mistakes, that patients were harmed, and that many of them just felt terrible and continued to feel badly for months later. And so all of this got me thinking. And so the first work that we actually ever did on this was back in 1991 in that first paper that wound up getting published in JAMA. Long answer to a otherwise reasonable short question.
I think our following questions do have a little bit of overlap, but they will, hopefully you can elaborate on some of the work that you've done. Our next question is, can you tell us a little about the origins of the term, the second victim?
So so I had written another paper which was something to the effect of how residents cope with their errors, and had done some work on disclosure of adverse events. In fact, I worked a little bit with Philippe Ibert at Sunnybrook in Toronto, and actually visited Toronto sometime in the late 90s. But in 1999, the Institute of Medicine's To Err is Human report came out, and just a few months later, Liam Donaldson, who was the Chief Medical Officer of England, wrote a paper which was called An Institution with a Memory, which was basically about the same topic. And later that year, the BMJ put out a special issue on patient safety, actually on medical error. And Don Berwick and Lucian Leap, who were editing that issue, asked me if I would write something. And they said, you know, we were interested in the stuff that you wrote about the impact of errors on residents. Can you write about that? And so I didn't need to be asked twice. I said, sure, I'd be happy to write something, but then I wasn't sure what to write. And I thought about it for a while, and it seemed like when I thought in particular about this intern who I'd worked with, and in fact, many other cases in which patients were harmed, maybe due to errors or maybe just had bad outcomes, that their doctors and their nurses, for that matter, you know, often felt terrible. And it seemed like they were victims of the same incidents in some ways. And so I thought that it just occurred to me that the term second victim might be appropriate.
Great. Thank you for that response. And you've already kind of touched on this, but our next question is, how close to home is this issue for you? And do you have any advice for helping a colleague in the aftermath of a negative outcome?
So I think this topic is close to everyone who practices. I think that all of us worry a little bit, almost all the time, that they're doing the right thing, and that, you know, you don't want to make an error. And then at the same time, there's all sorts of disappointing things that happen to your patients all the time in the hospital or in healthcare. So I think about it all the time. And I think that, on the other hand, it's sort of up to now, not everyone has been so aware of the issue. And not everyone is sort of equipped or in the frame of mind to respond appropriately when this happens to yourself, or more likely happens to a colleague. It's, you know, not every one of you online is going to make an error today or this week or this year that harms the patient, but something's going to go wrong with the patient, or there's going to be some surprising bad outcome with the patient sometime, you know, around you. One of your colleagues, one of fellow interns or residents, even a nurse, or there just might be a sudden bad outcome. And people are going to really be traumatized by that too, incidentally. And so I think that the first thing is to be sensitive to the fact that this is the case, and to understand that people really need emotional support and maybe a little psychological first aid, really, you know, at that time. And to also be to understand that you can say things that are hurtful or harmful. You know, I think that there is honestly sometimes a little bit of bullying in healthcare. Maybe it's just being macho, and maybe it's trying to pretend that it couldn't happen to you. You're not one of those doctors that makes mistakes. But people say things that are a little unkind sometimes, not always directly to the face of the person, but often behind their backs.
You mentioned providing emotional support or psychological 101. What would that look like?
So I think that what I would advocate doing is, I really actually think that everyone ought to be trained more or less at the same time as they do CPR to do psychological first aid, which is a thing. It was really developed mostly for disaster relief, and it's mostly showing up and listening empathically. But there's a little bit more to it. And in fact, if any of you, here we are. Here's my advertising plug. If any of you go online and look for the new journal, Patient Safety and Risk Management, issue 2 will be out in another month. And Fiona Gispin, who is a resident at Mass General, is the first author of a paper which basically advocates for psychological first aid training for all healthcare students. And so we believe that acting in this way, providing empathetic listening and support, basically, really as soon as possible, can be really helpful. And this is not debriefing and interrogating and getting all the details about everything that happened. In fact, it's really just providing support.
Okay, great, thank you. Dr. Wu, has your research or your observations shown any common patterns specific to residents post-negative outcomes?
I don't think that, I mean, I think that we have found some common patterns, but I think they're common to all human beings after these things. I think that if there's an error, I think that, you know, residents typically feel horrible and guilty and incompetent. And it's not completely, you know, unreasonable for an intern to feel like they're not fully trained and fully competent at everything, because that's the way it is. But people can really lose confidence and become very nervous and even anxious around patients, really gun shy. I've certainly seen people avoid patients that are similar to the patients that they saw who was injured somehow. It might be if you did a procedure, if you did a thoracentesis and gave the patient a pneumothorax, you might try to avoid all patients who ever need, a lung puncture again, and it's not very adaptive. So I think that all of those things are pretty common. People can get pretty distressed. People can have trouble sleeping. People can get actually quite distracted sometimes. And I've recently heard of a case where an intern got was so disheartened by a series of patients dying that she started to talk about committing suicide. So that's an extreme but real possibility.
What have you learned about successful debriefing strategies after negative outcomes?
Yeah, I think that one thing that we've learned is that a successful strategy after a negative outcome is not debriefing. In fact, there's a little bit of evidence that, sort of the debriefing, tell me everything that happened, and let's go over it so we can learn from it, is not the most supportive, and in fact is a thing that one can do, in fact, can be potentially harmful. It's the person's just beginning to regain their equilibrium, and then you make them relive every moment of it. What they really need is to know that people hold them in high regard and care about them, and let them talk about what their concerns are and listen sort of non-judgmentally and provide, emotional support. So I would say that we have learned that the best approach is doing less than you might think that we ought to do.
Is there like an appropriate timeline as to when a debrief would be appropriate? Because you said not right away. Yeah.
I think the most appropriate time would be after, everyone has returned more or less to equilibrium. People can be very upset for, certainly in the immediate aftermath of something, and easily for the next, next 24 hours. I think that, sort of immediately rushing in and, taking names and asking why, is not, might be a good thing to do to figure out what happened, but is not necessarily going to be in the best interest of the people involved. If you must investigate immediately, I think the thing to do would be at least to go in gently and say, boy, I know you must be having a rough time, but could we talk about this? We need to figure out what we can do to either to help the patient, which obviously takes priority over everything, or eventually to prevent these things from happening again. That rarely needs to be done, on the day that the thing happened.
Mm-hmm. Okay. And are there any red flags residents should recognize in themselves or their colleagues post negative outcomes?
Well, I think that people can so when something really stressful happens, people have acute stress reactions. And that's just something that, that happens to a human being when they're exposed to a car crash, an earthquake, if someone gets robbed, if you're in Baltimore, if you get mugged, or if you encounter, sort of a really bad patient outcome, perhaps if you make a mistake and the patient has a bad outcome, sort of all of those, the reaction to all of those things is pretty much the same, which is shock and, real sadness or grief, and maybe anxiety, and maybe getting very agitated, either that or dissociating and feeling very withdrawn. And I think sort of extreme feelings, if you were to experience any of these to the extreme, it would make sense to try to reach out to someone, just to give you some support. Certainly, if you begin to feel very depressed or completely, in some ways, unsafe, certainly if you have thoughts about, about self-harm, you should certainly seek help, even though, unfortunately, the instinct is to just hide under a rock and not ever speak to anyone again.
Okay. And one more last prepared question from our committee. Does our current model of teaching and learning support learners when they make mistakes, or does it contribute to the creation of the second victim? And what's your perspective on that?
Yeah, I mean, I could, I don't know about, whose current system we're talking about. I think that, God knows what they do in Canada, but, in the U.S., I think that all training is not sort of on a kinder and gentler philosophy. I think we tend to be, at Hopkins, there's a lot of talk about stiff upper lip and equanimity, keeping equanimity and toughening yourself up and sort of soldiering on. And that's not sort of that suggests to the interns and to the house staff that, that to show weakness is the worst thing you can do. And that's, seems pretty counterproductive to me. I think that people often are a little bit harsh about giving advice about how to improve. And people, sort of argue, oh, we want people to remember, we want, the most important thing is the patient. And that's true, for sure. But I think there's, sort of modern educational theory suggests that there's better ways to get people to learn things.
We just had a follow-up question from Irving Gold. Given the dual role that residents have as learners and clinicians, how do we change the learning environment to reflect the fact that errors are part of learning? And can we create a safe space for residents without sacrificing patient safety?
Yeah, so I that's a great question, Irving. And I think that, everything that you have to say is true. I think that our first responsibility, even as residents, is to make sure that you take care of patients as well as possible. They should not get worse care because they happen to be taken care of by a resident or someone who's less experienced. But I think that having an awareness that errors are all around us all the time, in fact, is an important part of doing a better job in taking care of patients. I think that having an awareness that medicine is error prone and human beings are error prone, and that certain things frequently go wrong over and over again in medicine is important, because then it's a little bit easier to avoid them. So I think what you can do is create a safe space for residents by being as open, at least in training, about things that go wrong and discussing them in a really as non-judgmental way as possible. So that what you're really talking about is what went wrong in the system, the system which included the residents, but what happened and what can we do, what can we learn personally to do better. But most of what needs to be changed usually is not in the residents, but it's really more in the program or in the system that's taking care of the patient.
And do you think that varies from specialty to specialty? So for example, medical specialties versus surgical specialties, where tolerance of an error?
It depends. I think there's really, I bet there's greater variation within institutions than across specialties. I think that there are microclimates in one unit versus another unit. One surgical unit might actually be very enlightened about handling errors, and another might be less so. Obviously, if some top person is very unenlightened, that's probably going to trickle down some. But a lot of the culture is driven by the local leaders, which might be chief residents, they might be unit directors who are nurses, they might be whoever's attending at that time.
Well, that looks like that's all the prepared questions that we have from the community. We do have a few questions from the audience today. The first one comes from Melanie Béchard. Her question is, do we see differences in response to negative patient outcomes depending on the age of the victims? And she's asking this question because she's a pediatrics resident, whereas it may be obviously a high-risk area.
So I think that, so we have a peer support program at Johns Hopkins, which is called RISE, which stands for Resilience in Stressful Events. And we have a team of about 40 trained peer responders who are nurses, doctors, chaplains, social workers, EMTs, and others. And they answer a page to call when someone calls to say that something very distressing has happened and you could use support. And while things started very slowly when we started this up in 2011, we are now probably getting 8 or 10 calls a month, which is not maybe that many for a 1,000-bed hospital, but is still quite a lot of people, you know, sort of calling in, often as groups as opposed to as individuals, needing some support because of something which was just a little too stressful, a little bit too upsetting. Most of the things are not errors. The majority, maybe 80% of the calls involve a death, and another big percent of some unexpected bad outcome. And I think that people always feel worse about things that are more preventable, where the person would otherwise might have, you know, sort of their whole life ahead of them. And pediatrics is a place where that's obviously the case. In pediatrics, in the neonatal ICU or the pediatric ICUs, also on cancer wards, often which involve pediatric patients. In the ER, when some of the patients are older, some of them are younger, all of these are places where I think there's some higher risk. OB seems to be a high-risk area because things almost always go well, but when things go badly, they sometimes go really badly. And on the other hand, ICUs, adult ICUs, where most people are not so young, happen to have a lot of outcomes and a lot of bad outcomes, and they're another high-risk area. So maybe bad outcome is one very important sort of influential factor, but there's more than that.
Okay, great, thank you. We have another question from the audience today from Julia Curtis. Her question is, many programs in our university hold M&M rounds, so morbidity and mortality rounds. Do you think they play a positive role in helping residents navigate and learn from negative outcomes, or can they also potentially be harmful?
So Julia, I really like this question, and I think the answer to your question is yes. Should I elaborate?
Yes, please, yes.
So, you know, I mean, I think that M&Ms are really important. I think that M&Ms are picked because they're salient cases. At least M&Ms here are not just picked necessarily because there's a bad outcome, but they're often picked because they're instructive. Sometimes there's something where there was a misdiagnosis, but they're not picked because it was stupid, but they were picked because it's sort of in a way easy to see how you could reach a wrong diagnosis, and the point of the whole thing is to figure out how to more often get to the right diagnosis. So I think that M&Ms can be very positive. I do think that M&M can be done in such a way that it really rubs salt in the wound of the people involved. And so it may help people, it may help everyone learn, but you may, you know, feel worse just even as you're learning more, doing better. And so I think they can be potentially harmful. And I think that being aware of that is important. There's, I don't have video that I can show, but there's there was a show back in the 90s called Hopkins 24/7. It was one of the first reality TV shows. And they basically somehow someone let people come in with cameras and roam around the hospital for like the whole summer. And one of the things they did was they filmed a surgical M&M. And it was pretty brutal, I have to say. It's just showing, even though people were well-meaning, you could see how the intern who was involved felt very contrite and said a lot of things that were sort of they weren't even sort of self-protective as they were sort of, self-flagellation. And, I imagine he did learn from it, but it was a kind of a tough experience. I think that it's possible to learn without getting, bruised.
Thank you. A few more questions here too. Another one from Irving Gold. How different do you think the reactions are for residents between negative outcomes that are unrelated to an error versus those that have a possible error involved? Irving believes that there's a shortage of supports for residents in both areas, but he's wondering what your perspective is on it.
So Irving, I really, I do see research questions in a lot of the questions that are being asked, and I think that I could envision, some survey research that perhaps this group could do that could look at reactions of residents to adverse events or negative patient outcomes. If you ask an intern at the end of the year, did any of your patients have negative outcomes? I think that you're going to get 100% saying, yes, at least some patient. I think that the less than optimal reactions are different for the two categories. I think that when there's a bad patient outcome, people don't really realize just how upset some people can be. And, someone might, the attending or the resident or the nurse might say, oh, bad break, or, oh, that was a tough one. But that's likely to be the last discussion you ever have about this patient who maybe you took care of for, a week or a month and really, got attached to. We all have we all have transference to patients to some extent, and we all have pet patients to some extent. One of my PhD students actually wrote a paper about favorite patients, if you want to look that up. When any patient does badly, or someone who you cared about one way or another a little bit more as a bad outcome, you feel terrible. And we, in general, do not provide support for those people in any organized way, certainly. I think that when there's an error, I think that you get more attention, but not all of it's good. In fact, a lot of it is not. And, there's a lot of talk about re-education and other things which sound a little bit scary around errors that have bad outcomes. I think that people do, in their good intentions to investigate what happened, ignore the fact that they're really, sort of also trampling on the people who were involved and making them feel bad all over again. And there's a program in the University of Illinois in Chicago, and one thing that they do is when they get a call, and all of their calls actually go to RISC, when RISC gets called about a bad outcome, they contact the doctor or the resident, but they also activate a peer support sort of person. So they try to provide support at the same time as they are trying to figure out what happened. And that, in a way, sort of makes sense because it's inevitable that the person is going to feel badly. And if you go and talk to them, they're not going to feel better. In fact, it's just as likely that they'll feel worse.
Thank you. And some more questions trickling in, Dr. Wu. We want to have one from Jennifer Clausen. Do you think there is a possibility to let trainees fail in clinical training to let them learn better without harming the patient?
I'm sorry. Could you say that again? I was trying to read the crawl myself. And I got.
Okay. Yeah. So it's Jennifer's question is, do you think there's a possibility to let trainees fail in clinical training to let them learn better without harming the patient?
Yeah, I mean, I think you should let people fail, but I feel that you should let them fail in simulation. Mm-hmm. And I think that your job in training is to never let people fail, because, by the way, their failing almost always involves a patient. I mean, I guess you could let them make the wrong diagnosis on paper and then let that inspire a discussion in which they see, you know, how the error was made and how easily an error could be made. That I think could be perfectly instructive, because it might help them see how important it is to say, avoid some of the pitfalls, some of the cognitive biases that lead to diagnostic errors. But with live patients, I think you kind of want to be careful.
Okay. We have a question here from Mike Sajan. Is there anything known as to whether Black humor in the setting of negative outcomes is protective and resiliency-promoting versus dehumanizing and ultimately demoralizing? And Mike is an emergency family medicine, emergency medicine resident. So I think Black humor is definitely, and I'm an emergency medicine resident as well. So I do understand where Mike's question is coming from.
Yeah, so I think that, you know, Black humor is inevitable. You know, it is, you're going to encounter it in any area where there's, you know, where there are a lot of bad outcomes. I had incidentally had a discussion yesterday with some people who work in rehab, and you know, and they, you know, these are people who are patient transport people, and they were talking about, you know, this person, this quad and that quad, and you know, I think it's inevitable, again, if you're surrounded by, you know, sort of terrible things, almost the only way, one defense mechanism is Black humor. I do think it's also, you know, even accepting that, I think that it is kind of cynical, and I think it can be dehumanizing. So I don't think you can root it out, but I think you do need to understand that even if you engage in gallows humor, I think that you don't want to do it at the expense of, you know, then caring less or paying less attention to a patient.
Okay. We have another question here from David Alders. And his question is, I guess so he's a surgeon, and he's been using verbatim theater, I guess a stage play based on interviews with residents, as a way to try to encourage people to engage on a deeper level. What ways have you found useful to get more engagement and discussion for the public, the profession, and between the two?
Yeah, so I love that idea, and there have been a few award-winning plays that have been done about medical errors, and that I think are quite revealing, and because they're done so publicly, you know, people can be critical and have time to reflect on what they're hearing, and what may seem perfectly reasonable, you know, in the moment might, when you think about it, really realize is sort of not a good way to communicate. On the other hand, it's a safe way to learn vicariously. And so this is another example of if you're going to make a mistake, even a mistake in communication, you know, it's better to do it in that situation than and let other people learn from it. I think that one way to do things, which also takes the risk away from the patient, but and allows people to practice, is role play. And I think that you do. I think that you know, I think stage play and role play are pretty similar in a lot of ways. I think doing things with simulated patients also can sometimes really can feel real enough that you really learn from them. And I think that whenever you involve patients or family members, members of the public in some of your educational activities, it really changes the tenor of the discussion. You're much less likely, for example, to engage in Black humor when you've got, you know, a patient or a small child or other family members in the room, and, you know, behave more like you might ideally like to behave perhaps more a little bit like your ideal self?
Great. Those are all really fantastic questions from the audience. We still have some time left, and again, I'm just opening up to the floor if anyone else has any comments they want to make or anything they want to share.
While no one is asking a question, I do, I don't know how big this group is, but I do think that you have the interesting opportunity to do some research and perhaps do some training and research around the training or evaluation of the training. And because you have different organizations, you could actually do experiments. You could do sort of cluster randomization of different interventions in different institutions. And even though they're not really, randomized control trials, I think that you could learn a lot from them, and it would be relatively easy for you to do. So I would really encourage you to around some of the questions that were asked. Some of the things might involve an intervention. Some might just involve a survey. I would try to get some of these questions answered.
We have just a couple more questions just came in. Irving has another question here. Do you think programming in this area should be an accreditation standard?
So, yeah, I think it probably should. I think that we in the States, patient safety is starting to appear on, board exams and things. And in our medical school, all students are required to get a block of patient safety in the second year of medical school. And it includes disclosure of adverse events to families. It involves, increasing awareness, at least about the second victim problem. It includes reporting errors and handling errors. We also are requiring now all of our hospital staff to take what's probably basically a 20 to 30 minute online basic patient safety 101 block. So we've probably, because it's required, we've trained, last year we trained 35,000 people using this online module that we can certify that they all took it. And I think that just having a little bit more awareness, I think, is really important.
I think that's great, yeah. Another question from David Alderson. Have you had any negative responses from patient groups about the term second victim? I guess it could be taking away from this centrality of the patient's experience of what happened.
Yeah, absolutely. I think that some patient groups are quite negative on thinking at all about the feelings or the possible, harm that could come to patients, to providers around, the same incidents that harm patients. I think that there's a couple of reasons for that. First of all, many of the most disgruntled people, the strongest patient advocates are people who've been harmed by healthcare, by, what we would consider to be medical errors, and then have been mistreated by the system. They were stonewalled, or they were not, they didn't get any consideration for years at a time, and they're really angry. They feel like they were mistreated, abused, and it's very difficult for them to view the doctors or the nurses, who they view as the perpetrators or the villains, as being victims. So I would take those feelings a little bit separately from those of the public in general. And I think it's relatively easy for people to understand that doctors have feelings. You would like them to be feeling as well and as good about their work as possible, so that if nothing else, they could take good care of you. A happy worker is a good worker, and that's not, only at Disneyland.
Thank you. And we have one comment from Alan, and excuse me if I pronounced your name incorrectly, but Alan's a clinical teacher, and their comment is, I think it is very important that we model how to handle our own errors, owning them, examining what went wrong, and working to improve the system, and teaching about it can be helpful for both learners and the teacher, to say nothing of the system, which can always be improved.
Alan, I think that very wise comment, and I think that first of all, as educators, we need to model these behaviors. If medical students or residents hear about this in a class, and then when you talk to your attendings about it, they roll their eyes and say, "Oh, that's crap," then is this being recorded? And then I mean, they're gonna sort of that culture will culture always trumps policy. They say that culture eats strategy for lunch, and if there is that internal curriculum that that fights against sort of more enlightened and more productive attitudes towards safety and this whole issue, then I think that you're going to lose. So role modeling is really important. When I was doing my research back as a fellow, I was at UCSF, and a senior attending there who was very well loved, Molly Cook, stood up every year for the interns and talked about the worst mistakes that she'd made when she was a house officer. And people sort of remember those things. People still can remember the stories that she told. One story she told was how she was working in the ER, and she was rushing to get out at the end of a shift because she had to do something with a child, and so she didn't check something before she left. And it wound up being something that was a consequential test, and the patient was harmed as a result. And this was a very important mistake for her, and a patient was harmed in addition. And I think that everyone who heard that story thought about that incident, and even occasionally when I've been rushing to get something done, her message was, it's at the times when you're rushing and you cut corners that things are more likely to go wrong. And, and I still remember that. So I think that those role models are so important.
Great, thanks. And looks like another question just came in from Julia. Do you think fear of litigation prevents people from seeking help when they were part of a medical error? And if so, how do you think we can overcome that fear so that people can more freely seek the help they need when dealing with a negative outcome?
So Julia, I think that I agree with you 100% that that people are afraid of litigation, and this may be the case in Canada, but it's certainly even worse in the U.S. I think, and I think that the part of the reason that they're afraid of seeking help is because, in fact, they will not necessarily be treated well if they do make reports. I think that it doesn't feel safe to report anything. You might be punished, or you might be sued, or both. In fact, most organizations are set up in such a way that they would like to protect you because it's, if nothing else, it's self-protective. But I think they don't do a good job at convincing people that it is safe and that they care primarily about, at least not, if not primarily, they also care about you and if they've got your back. I think that creating policy having organizations create policies that and statements that that they support their healthcare workers, and they're very they're crucially interested in the well-being of their workers at all times, I think is really important. And I think setting up systems that are really confidential and even anonymous, I think are important. That's part of the reason that we have our RISE program, and why it's become more successful, because it's completely confidential. We don't take names. We don't report to anyone. There's no report ever made. And it's something that is clearly simply for the benefit of workers and not related to patient safety, not related to risk, not related to medical legal, not related to HR or anything else.
That's great, great response. We have another question from Irving. Aside from research, what is the one thing that we, as resident doctors of Canada, can do to help our system to discourage the creation of a second victim?
Yeah, I think, I mean, it depends on what level. You know, I think that as residents, you can encourage people to support each other, to be aware that, you know, in fact, we're relatively fragile humans in a very, very stressful system. And that one of the best things you can do is be as supportive of your colleagues. And by that, I mean fellow doctors, but also nurses and other people who you work with all the time. The second thing you can do is encourage your organizations to, you know, to state publicly their support for, for their workers, including their residents, and to, you know, put something behind that. The Joint Commission actually just put out an alert, a quick alert last month, I think, and they basically said that hospitals should develop systems to support healthcare workers who might be second victims of patient adverse outcomes. So that's the sort of thing that I think is certainly needed in Canada too.
All right. So it looks like we're almost about to wrap up. We have about 5 minutes left. Again, I just want to reach out to the audience if anyone has any last questions here. Jennifer has another question here. Which do you think is the best educational strategy to learn from failure individually and I guess as an organization?
Yeah, I think that fortunately we do not have personal experience with making all errors. And so I think that publicly discussing and analyzing and going through what went wrong when things go wrong is one of the best strategies. I think honestly that educating everyone about the science of safety is crucial, because I think that everyone needs to understand that there are things that can easily go wrong and are almost guaranteed to go wrong, so that you are aware of that, you are able to head things off before they happen, you're able to react quickly and try to recover when things do happen, and you can point out when things can be fixed in the system so that it creates more resilience in the whole system.
And I think just one last question here, and we did start a little bit late, but from David Alderson. Are there limits to candour after an error beyond which further harm may occur both to the patient and the clinician, or should disclosure be absolutely full and frank on all occasions?
Yeah, I mean, I think that it's a good question, and I don't think it's really been studied, systematically. I think that when you present people, mostly patients, with simulations about full, partial, sort of padded disclosures with guardrails, people always want to know everything. So that is what the public has said, but it's not in cases where things actually occurred. Michelle Mello, who is at Stanford, has done some really interesting research on this lately, doing in-depth interviews in closed cases of patients and families who were injured and who sued and settled, or whatever the cases are concluded, and they were asked about how the disclosures went and what they wanted. I think in general, you should not ever keep two charts. I think that you shouldn't tell the patient some things and then tell your colleagues other things and then document just a few things and absolutely don't tell the lawyers anything. I think that it's like telling a lie. Once you've told a lie, you have to remember who you lied to and what you said to whom. And, you know, that's a losing proposition. So in general, I think that being as transparent as possible, telling people what you know, as much as you know, but and not more, so that you know what they know, because after all, you're all really on the same side, is probably the best general policy. I can think of some exceptions, but I think that they're rare.
Great, thank you. And I think this brings us to about a close. We're just right at 3 p.m. Eastern time. And so this was fantastic discussion in this new venue that we are trying out with Resident Doctors of Canada. I just want to, on behalf of Resident Doctors of Canada and the Wellness Committee, I would like to thank you, Dr. Wu, graciously for your time today, sharing your expertise and your experience and your insight into this very important topic to us. I think you've really empowered us with some ideas and potentially some research ideas. To end off, I also just want to say thank you to a few more people who made today's event possible. Gail Leger and Todd Coopy from Resident Doctors of Canada for doing all the background work, the logistics, the organization, and the communications. And this event would not have been possible without you two. I'd also like to thank the Wellness Committee members for, again, also had a part in organizing the event and also being champions of physician wellness and health in Canada. And I also want to just thank Dr. Jason Frank, who's a clinician educator from the University of Ottawa, who actually suggested that we get in touch with Dr. Wu for today's chat. Well, this wraps up today. I want to, again, thank you everyone for joining us and taking time out of your busy schedules to participate. Hopefully this has been valuable and impactful session for all of you. And we look forward to hearing from you and to seeing you again in the future. Thank you.
Thanks, everybody. This was a nice discussion. I think that you guys could do a lot. I wish I'd belonged to a group like this when I was a resident. So anyway, enjoy the rest of your day. Go out there, take good care of patients, become smart.
Thank you.